Hello and good afternoon. Thank you for joining us. You've reached the COVID Weekly Roundup. Today is October 2nd, 2020, and it's 1 o'clock in the afternoon. My name is Jason Belden. I'm the Director of Emergency Preparedness for CAF. And with me today is our guest speaker, Deanne Walters, Director of Clinical Affairs from CAF as well. And Deanne's here to give us some context to the visitation stuff. And we'll get to that in a minute. I have AFLs there listed plural, but really there's only one AFL that came out this particular week. We anticipate something dropping either Monday or possibly this weekend in regards to the AFL on visitation. But we're going to cover AFLs, the visitation, what we expect to see from that. We want you guys to, have your processes and plans in place to get started pretty quickly. We'll talk about PPE and CalOSHA. We assume that most of you guys participated in the CDPH and HAI calls on Thursday afternoon, and there was some confusion with the speakers there, and we're going to clarify that just to make sure. I think folks that regularly participate in this webinar probably understand that, but I just want to cover it so that everybody knows. And then we'll talk about legislation. A number of bills were signed by the governor this past week, and we want to go over those because some of them have immediate impact to skilled nursing providers, as well as intermediate care facilities as well. So, all right. All right, so as an introduction, the speaker's opinions expressed are their own. They may not reflect CAF's official position. These webinars are grant funded through a program called the Hospital Preparedness Program, and CAF has a grant through the Hospital Preparedness Program that funds these webinars as well as my salary as well. We have no financial conflicts. I'm an employee of CAF and under that grant. The intent of the webinars is to give you a situation report with some forecasting and best practices. All right, so first update, I'm not going to dive into this because we're going to talk about the visitation and the legislation pretty extensively. So, but just to make you aware that effective October 1st, meaning yesterday, all Medicare and Medicaid nursing facilities are to use the revised MDS. There's the link to the AFL if you have other questions about it. If you've not seen this, go ahead and take a look at that. All right. So I wanted to ask Deanne to come on because we've developed some outdoor visitation guidance, and that is currently available on our website. So if you've not already done this, I don't want to say you should have already started it, but definitely you want to get around, wrap your head around this because visitation is coming. And the question is, how are you going to do it? And there's not going to be there's not going to be an ability really to restrict visitation. There's going to be some limitations to it, and I'm going to go over those, those limitations. But for the most part, all of us are going to be open up for visitation. The question is, are we going to do it outside or inside? Did you have something you wanted to?
Yeah. I was just going to jump in. Everybody can, refer back to the June 25th AFL, which says that we must provide outdoor visitation. So this new AFL probably will not just not change that, but will go on to give direction for indoor visitation. But we know that it's been a challenge because some of it is staffing, some of it are other items that are getting in the way. But truly, based on the June 25th AFL, there should have been some movement towards doing a minimum of outdoor visitation. And hopefully, most of you are already in that place so that your systems are strong enough so that you can then now make the next step into indoor visitation. But you can refer back to that in the meantime, but definitely want to be aware that outdoor visitation should already be in the plans in your facility.
Yeah, and that's great advice, Deanne. And if you've been holding off for whatever reason, maybe you were in an outbreak and you just haven't had the opportunity, or your outdoor visitation space was limited. Now you're going to have to look at, well, we're going to have to do visitation. We're going back to some semblance of normalcy, for our visitors. What's going to be the safest for our residents? And CDPH and well, we don't know what CDPH is going to say, but we know CMS has said that all visits should be held outdoors whenever practicable. And we anticipate CDPH to say the exact same thing. They're going to encourage the visits to remain outdoor as long as you can accomplish that. So, and many of these things that we have listed under here are going to be consistent with indoor visitation as well. So when we talk about scheduled visits, you're going to be expected to schedule these visits, or you can schedule these visits rather than have just folks show up whenever they want to. Physical distancing and face coverings will be required. We know that for sure. I don't have to guess on that one. I'm pretty certain that that will be required. Staff monitoring of the visitation to make sure things like infection control are procedures are being followed. That's going to be that I don't know that that was specified in the CMS QSO, but we anticipate that CDPH is going to require that staff monitor the visits to make sure that infection control and infection procedures infection prevention procedures are being followed. So, and there's going to be a substantial requirement on family communication. All the components that go into that will be spelled out in the AFL, but imagine it's going to be very consistent with what you're already doing for your communication with family members and things like that. So, and I went over that first bullet point, but I didn't really talk about it at length, but we do anticipate this to probably Monday, maybe sooner. I don't know. The expectation is CDPH will be covering this on their Tuesday morning calls. They're all provider calls. I think that's their plan. I don't know if they'll be able to pull it off, but so we do expect it to be released very soon and with a short implementation date. And I'm guessing on the implementation requirement. I don't know that for certain, but based on how quickly they required us to implement the testing, I think it's safe to assume that they will anticipate that you can resume visitation very quickly after the AFL sent out. Do you agree with that, Deanne, as well?
I would agree with that, mostly because since the QSO has been out for now, by the time they release the AFL a couple of weeks, they'll have imagined that we have looked it over and started developing some plans on how we will do indoor visits. So they'll want us to turn it around pretty quickly.
Okay, yeah, and I think it's probably safe to assume that you guys should work on having this in place when the AFL comes out, just in case if they say it's effective immediately, you're ready to go. So the real change to our procedures or our daily operations is going to be this inside visitation. We know the inside visitation is going to be subject to county positivity rate / color. CMS has changed how, I don't even know how to put this. Instead of saying positivity rate, now they're saying, look at the color of your county. And if it's red, you're in one category. If you're in green or yellow, you're in other categories. It all boils down to the same percent, the same kind of thing. At the current time, I checked the CMS website on Wednesday, and we had no counties in the red category. So, and I don't know if the CDPH AFL is going to reflect when you should be checking the county positivity rate or the county color code. But I know that your inside visitation will be limited if you're in one of those counties that's above 10%. So if your county goes back above 10%, then you would have a little restriction to your inside visitation. You'd still be allowed to let it happen, but the conditions would be limited, let's put it that way. So for inside visitation, we anticipate that you're going to be required to have like an approved testing plan and mitigation plan in place. So meaning you've already been approved, you've already talked to the district office about your testing once a week, all healthcare workers, and then and that's addressed in your mitigation plan. And all of this stuff, I'm gonna give you kind of where you can find, when the AFL comes out, the way that I've seen the draft written is written in a manner that we can take, really cut and paste a big portion of it and use it directly as our procedures for visitation. And so at least that will be helpful in the paperwork process of adding this to our mitigation plan. But I'll cover that in a second. You can't be in response testing or have in a current outbreak. So if you're currently doing response testing as a result of an outbreak or things like that, you're not going to be allowed to have open visitation, inside visitation during that time. You're going to need to monitor what's called the core principles. I went over that a couple weeks ago, the CMS core principles. It sounds like a lot, but really, if you read the bullet points from the core principles, you're like, oh, we do every one of these already. We're already doing these. So, but we'll touch on those in a second. This is an important one. So the visitors would be limited to one at a time. And the total visitors would be limited by capacity. So what is your capacity? What is the indoor space? And do you have enough staff to be able to, to monitor the visitation, to schedule it, to do all that stuff? And the bottom line is you get to choose, what the limitations of your space are. Don't allow anybody to dictate what is safe for your residents. That's your choice. So you get to make that decision. But we're not allowed to just say it's unsafe as a blanket statement and not allow anybody in. We're going to have to let folks in. So we have to figure out how we're going to do that. Once visitors come in the building, we know they're going to be limited in their movement. They're not going to be allowed to go to other parts of the facility. They're going to go to specifically where they're going to have their visit, and they're going to leave from that spot. And that we anticipate this, and this is in the CMS QSO, is that the suggestion is we would prefer, or they would prefer, a single room visit, but if the folks are not in a single room, then we'd need to come up with a designated area for where we're going to hold this visitation. All right, if we hadn't mentioned this, visitation will be mandatory. They've cited the elements in the Federal Register that basically prescribe us to allow visitation, but this will be subject to local health department change. And this is one of those things where we get in this this mode where we receive guidance from feds and the state that may conflict with what our local health department is doing. And it may be in counties or in health departments where you have a much more conservative approach to allowing visitation. They could come in and say, look, we're going to restrict it up to and including restricting visitation altogether. So they are not, I think most of them are going to follow along with this, but I'll say that there could be some variability based on what your local health department does. Los Angeles has pretty specific requirements, and some of that conflicts with what the state has said, or is more conservative. I shouldn't say it conflicts, it's just more conservative than what the state has done. So things like that, when you ask those folks at CDPH on those statewide calls, they don't really have an insight into what's happening in the local health departments specifically. They may hear things. So when you ask them questions, they're only giving you answers based on what the state guidance is, and your local health department could be quite a bit different than that. So you may restrict visitation under these, kind of categories. So if your positivity rate is above 10%, or you're in the red category, doing outbreak testing, we mentioned that. The resident's COVID status. So if they're COVID positive, we're not going to have visitation during that time. If they're a suspect COVID case, we're not going to have visitation during that time. The easiest way for me to wrap my brain around this is think about the folks that you have in your green categories. That's the easiest way for me to wrap my brain around it. and how it's not very nuanced, but it just makes it easier for me to think of it that way. The folks in the green, these are the folks that I'm looking at doing this for. And lack of adherence to infection control. And while we don't know if they're going to write into the AFL if you have the ability to stop visitation midstream if you see a lack of adherence to infection control. So a visitor comes and decides they don't want to wear the mask anymore, then we don't know whether we would be allowed to terminate that visit. But our assumption is you're going to be able to kind of monitor that and ask folks to leave. We haven't got basically CDPH to say that's okay yet, but certainly I think it's within the realm of you being able to take a look and make sure that folks are following the guidelines. And I don't know what to do.
I'm going to jump in.
Yeah.
Oh, sorry, Jason. Just to say that, this is where your documentation is going to be really important when you're looking at how your visits are conducted, is if you have an individual who is refusing to adhere to your infection control or even your visitor process, you make documentation around that, and you then have the right to limit their visiting in the future. Because if they're going to put themselves and your residents at risk and your staff at risk, and you have that documented, then that's going to allow you to restrict them in the future. So having a process to be able to document that will be really important as well.
Sorry about that, Deanne. I don't know what I did, but the slides slipped ahead like 4 slides, so I apologize.
No worries. I just thought you were just cutting me off, so it's all good.
Yes. So we anticipate the visitation AFL is going to contain some infection prevention guidance. And the infection, if it comes out in the way that I've seen the draft written, it's going to have a lot of good stuff in there that's going to not require you to do much with the documentation. It's going to contain the IP guidance. It'll require core principles, and there's a link to the QSO if you want to go download that. I think it's on the first or second page of that QSO, has the bullet pointed core principles. But there are things like, screening staff, source control, testing plan, mitigation plan, things like that you guys already have in place. So that's great. It's consistent with what we have been doing. But now would be a good time to at least review those screening procedures to make sure, if you've had them in place since the beginning of COVID, just go check to make sure that the screening procedures that you're currently asking folks is consistent with what's being produced by CDC right now. So if you do a Google search for CDC screening questions or things like that, you can pull up a list. The CDC even has one of those like infographics with like 9 different pictures of different symptoms. You could download that and have that at your check-in station, your screening station, and that talks about all of the symptoms that you should be screening for. We don't anticipate a requirement to have visitors be tested. So I don't think the AFL is going to require you to test visitors in order for them to come in. And consequently, I don't think you're going to be allowed to refuse them to come in if they have not been tested. What we do think is going to happen is you're going to be allowed to offer them to be tested with one of your antigen testing devices. We don't know that for sure because we haven't seen it, but the CMS QSO speaks to it. So I anticipate CDPH is going to adopt this. I'm 98% certain of that. So if you're thinking, gosh, I'm not really using my antigen testing devices based on cost, or I have a good relationship with my lab, this may be a good modality for that. But if you test these folks, it still follows the same requirements. So you need a physician's order, and you need to report the results of the test through your CalReady system if you've already got it set up. So it's not just as simple as running the test and yes or no you come in. It's yes or no, and we have to report that we took that test, and we have to make sure it gets ordered. Communal dining and activities are going to be allowed to resume under specific conditions, green only. So we're not going to cohort the folks that are COVID positive or any of the suspect cases or folks on quarantine or isolation. Like I said, I know there's a lot of nuance in what goes into the yellow, and I hear the folks from CDPH, HIAI, but for me, when I look at it in terms of operations, I want to think about in terms of the categories, who's allowed to move freely within the building. And we think that the communal dining and activities are going to be allowed just for the green. I don't anticipate anybody else will be allowed to leave or allowed to have communal activities and dining. The specific conditions are going to go past just the green. It's not opening up your dining room and having folks sit next to each other. It's all of the same kind of core principles. We're going to do physical distancing, source control, cleaning after, all of those things that go into that are still going to be required for communal activities and dining, but at least the folks that are in green are going to be able to get out of their room more frequently now. So, and I want to put, I just want a little extra bit of caution. There's tons of talk about, how easily is COVID spread? Is it airborne? Things like that. When I look at communal activities and dining spaces, we know that was a big driver of large outbreaks when we got started with COVID. And that's before we practiced source control and some other stuff and screening folks. But if you have residents that leave the facility regularly, they have exposure every time they leave the facility. And now sometimes they're going to a dialysis center like one of the major ones, and the dialysis center is set up a great program for infection prevention and control, and they treat the COVID. They kind of cohort people based on their COVID status, and they do real well. And then there's some other smaller dialysis providers that have not had as good of a track record doing that. So if you have folks that leave your facility regularly like that, and they're in your green section, if they've not already contracted COVID and recovered from it, if their green has never had it, and they leave the facility regularly, I would be cautious about having them cohort with the other folks in communal activities and dining. It's just a vector of potential transmission. And if you're going to have a bunch of folks in a room with little airflow, it may cause a condition that I think at least you should be cognizant of. And if it was me, I don't know if I would have those folks doing group activities until we can get a handle on what the risk is when they leave the facility. So I just wanted to throw that out there as a best practice that you guys can consider. All right, so I want to hop forward and let me check with you, Deanne. Was there anything else you wanted to mention on the visitation before I move to the PPE stuff?
No, I think that you covered it quite well, and we'll see what CDPH has for us hopefully this week. Yeah,
for sure. And guys, I don't anticipate it to be hugely different than what we're presenting here. If there's going to be differences, they're going to be small, but this is based on information that is out of the QSO that we know they cannot change. They can't go less restrictive from that. So we put that in there. We're fairly confident that that's going to be pretty close to what we see in the AFL. All right, I wanted to move on to the CalOSHA PPE issue because I heard on the CDPH HIA call yesterday that the folks from CDPH answered a question. Well, I'll just say that it's in conflict with their own guidance, and it's definitely in conflict with guidance from CalOSHA. So let's just clear this up right away. N95 respirators cannot be reused in the state of California right now. Maybe in the future we can do it, but you can't do it right now. So extended use of N95s is all that's allowed. And so that means that you can give a healthcare worker an N95 mask for their duties, and that can last them their shift. They can don and doff that N95 mask no more than 5 times during that shift. And the shift at a maximum can last no longer than 16 hours. Now, ideally, it should be an 8 to 12-hour shift, but if you got somebody working a double, in that instance, CalOSHA says it would be okay to extend it to the end of the shift, provided they have not donned and doffed it more than 5 times. That is the rule. The rule's not changing. Well, it may change in the future and may become more restrictive, but right now that's the rule. So I hear a lot of questions, and I don't want to be ambiguous about this. CalOSHA has been really consistent, and CalOSHA oversees workplace safety for all of our employees. CDPH does not. And so CDPH may give guidance as to how to use an N95 respirator or where they want you to use it, but really it's CalOSHA that is the regulator for personal protective equipment for our employees. So what they say goes. It doesn't really matter what CDPH says unless they have a more restrictive rule. So we've got to follow CalOSHA. Now, the metric or this chart you see in front of you is a part of an attachment of the PPE that came out last week. And so if you look at this, the guidance from CDPH itself clearly states you have to use an N95 respirator, and no longer allows reuse at all. So if you're saving your N95 masks and you're putting them in a plastic or a paper bag and you're holding on to them, that's fine. You can hold on to them in case we get a surge in the fall from flu and there's a crisis with N95s and we can no longer get them, that we can put those back into service then, but until then, you would just hold them and store them. So I wanted to make that clear. Is there anything else, Deanne, that I missed on the PPE that folks had questions about?
No, that was really, I think the biggest concern was that the question was about, we give our employees 5 and they use that throughout the week, 1 for every day of their shift, and then they bag them. And knowing that was violating CalOSHA, we just wanted to bring that back up and make sure it was very clear so we don't have anyone here violate CalOSHA and end up with fines.
Yeah, and the other thing that they stumbled on a little bit yesterday on the call was the testing. And here I'll say it unequivocally: every SNF provider in the state has to test their healthcare workers 100% a week. That's it. It's at a minimum. So that's your minimum. You could certainly do more than that if you wanted to. I don't know anybody that would do that, but so I heard questions asked, what's this, what's that? It's 25%. No, it's 100% per week, every facility in the state. That's a blanket. it applies to all of us. So we all have to do that. So I wanted to talk a little bit about discussions we've had with CalOSHA. I talked last week about a number of enforcement actions, and we really wanted to get in front of the leadership of CalOSHA to talk about the realities of how this, how we got to where we are, and kind of develop a framework for how we go forward. We don't necessarily have the framework set for how we go forward, but we had a very productive meeting with the Director of Department of Industrial Relations, which oversees CalOSHA. So we had been talking to CalOSHA's leadership, and we've had minimal success in engaging them. And a part of it may be they're extraordinarily busy, and they were a very small portion of what they oversee. But we finally got out in front of the director, and that was great. So we were able to give the director a historical perspective from our side of kind of the discrepancies in guidance, the availability of PPE throughout this, the guidance on the use of PPE and how that's conflicted from CDC, CDPH, and CalOSHA. We talked about all of those things, and the good thing about this was, well, I don't know if it's a good thing or a bad thing, but the director was unaware or was unfamiliar with the length or the breadth of the problems that we had faced, specifically around PPE from the beginning of this epidemic. So it's good to give them that historical perspective so that they can understand that, you know, from a provider side, back in March and April, we were telling providers, and CDPH was telling providers, was to conserve N95s for later use, and encouraging surgical masks or other face masks to be used when an N95 would have been more appropriate. And so we look at all of those things that you guys were following from clinical guidance that were in conflict from what CalOSHA was requiring. And so we laid that kind of groundwork out. And our hope is that by saying, look, many of these enforcement issues were unavoidable. A provider through no circumstance could have been compliant during some of these issues. And I think we were very successful in at least pointing out how large and wide scale the problem is. We talked about our current situation with supply, what their limitations are. We let them know that we regularly speak to the manufacturers and the suppliers of the PPE so that we get an understanding of where those limitations are. And we point blank told her, you know, we still have massive issues with getting fit testing. And we asked them to, well, they had said that they're going to create a series of educational sessions about, you know, CalOSHA, what they have, what they oversee. So things like PPE, workplace violence, you know, things like that. We asked them specifically, could we get a train the trainer fit testing video? So could we get a video that CalOSHA does that tells us how to do the qualitative fit testing so that we can do our own fit testing? Now, we still can't find the fit test kits, or they're hard to come by. But if we get a training video that's a train the trainer, it will give us kind of the education on how to do the fit testing, but two, kind of something that we can put in our documentation that says we've gone through the CalOSHA fit testing training, and that's what the training that we use to develop the fit testing for our employees. So that was the first like major thing I asked them for help with. I told them, you know, we probably don't need donning and doffing videos. There are lots of free ones out there available. And if our folks are having problems with that now, they're probably going to continue to have problems because we've done this ad nauseum for 6 months now. So, but it was a very successful meeting. And I think going forward, we've got CalOSHA's commitment to join CAF for some educational sessions. So as we get closer to that, I highly encourage you to reach out to us and let us know what kind of stuff from CalOSHA would you like us to engage them to get training on, whether it's the workplace violence prevention plans that are required in every healthcare facility, or is it information on PPE and all that other stuff. And the other thing we mentioned is how the inability to be able to use elastomeric respirators, especially when we have a significant portion of our resident population that has dementia. So we brought that up to her, and we asked that they change their guidance to not require a schedule that you need to go through before you get to an N95. So if you read the CalOSHA guidance, it really kind of says, you know, use a PAPR first. If a PAPR is not available, use an elastomeric, and if elastomeric is not available, as a last resort, use an N95 mask. And we want them to change that because we're never going to use the first two, so or very rarely use the first two. Can we just say choose one of these three and you're compliant, rather than having to go through this process of ruling out the others before you get to the N95? So very productive call, and let me know if there's training you want to see from CalOSHA specifically. All right, I want to talk about legislation because a couple of these bills are effective immediately, which means they're in effect today. And we have some handouts that our legislative director, Amy Blumberg, has prepared. And so if you look in today's handouts, there's a handout of the slides, as well as 3 handouts on specific legislation. And I'm not the legislative director, but I'm just going to mention a brief kind of synopsis of what this bill is. And so AB 1867 expands the Family Leave Act. The bill is intended to close the gaps between COVID-19 related sick days under the FFCRA and the governor's executive order that only provided leave for food sector workers. So now they're going to expand that. It's other types of healthcare workers are going to be included. Private businesses with 500 plus employees nationwide will be affected. There are even more employer groups that are affected. So I highly suggest you see the handout. The way it's written, I think most facilities would be impacted by this. Deanne, is there anything do you know anything about this bill at all?
Not enough to speak on here, no. It's just, yeah, the additional family leave. So sorry, this one I haven't studied up on.
Yeah, this one, I think, guys, you definitely have to read it because I think it has immediate impact for each one of the facilities. So definitely take a look at it. And so if you're a part of a multi, we know you're definitely going to be involved in this because they're counting employees, even out-of-state employees, as a part of your employee for this Family Leave Act. All right, the next one that's effective immediately is Senate Bill 1159. It's the workers' comp bill. This bill expands access to workers' compensation by creating a rebuttable presumption for healthcare workers and other frontline workers. So think EVS staff, dietary workers, physical plant staff, things like that, that these employees got infected with COVID-19 at work, which means that they're basically saying it's a workers' comp claim if somebody gets COVID-19 and they work in a healthcare facility. It establishes a rebuttable presumption when there's a workplace outbreak, which means that if you have an outbreak in your facility, they're going to say unequivocally that the COVID-19 exposure came from work. And then it does reduce the time that you have to contest these workers' comp issues from, I believe it was 90 days before, and now it's 30 days now. So you have a really shortened time frame to contest these claims. All right. Another one effective immediately is SB 1383. This is the Paid Leave Act. And I don't know if this necessarily changes stuff for SNFs, but it definitely, if you're an ICF provider, it definitely changes stuff for you guys. So if you know about the Family Paid Leave Act, it allows for unpaid leave of an employee due to family medical issues or their own. It could be intermittent. There's a lot of kind of nuances to that. But there was a threshold for however many employees you employed before you were subject to this. And now that threshold has been dropped to 5 employees or more. So it means everybody on this call, their employees will be eligible for unpaid leave if they've worked more than 1,250 hours in the last 12 months, or approximately 26 hours per week. So if you've got a part-timer, the part-timer may actually count for this as well if they've worked over 1,250 hours. And we have a more detailed description of these 3 pieces of legislation in the handouts, as well as SB 275, which I think is the next slide here. Yeah, okay. So SB 275, this is the big PPE bill. This requires all healthcare employers to maintain a 45-day surge level inventory of new, unexpired PPE for use in case of a declared emergency beginning January 1, 2023, or 1 year after the DIR has adopted regulations. And so we've got some kind of a glide path to implementation of when this is going to be required. And then it's, well, we had a bunch of discussions with the author revolving around this bill. It had originally started as a 90-day or a 6-month supply of PPE we managed to get it down to a 45-day surge level of PPE. It's still going to be really hard to do from a space perspective, but CAF is working on costing out what this is going to cost to providers so that we can get some reimbursement for that. As well as CAF is going to sit on the stakeholder group, and I assume it's going to be me, but we'll sit on the stakeholder group that kind of, because what is a surge level? That has not been defined. What is the type of PPE that will be required? That has not been defined, but it will be defined through a stakeholder work group process that CAF is going to be on. We anticipate there'll be other folks from, folks like Canner will be on there, folks like SEIU will be on there. So it'll be a broad stakeholder group of folks that'll come up with this, but we'll definitely work with them on realistic expectations. I think once they see what 45 days worth of glove usage looks like, they may think twice about requiring us to do gloves for 45 days when it's 8 pallets of gloves or something like that. So we'll work through that. We've got some time for implementation. We've got some time to work on the reimbursement. This is not going to be immediately effective for you guys, so that's good news. We're still a few years out from this being effective. All right, so AB 685 was another piece of legislation that passed that requires reporting, and it requires employers to report COVID-19 outbreaks to local public health. And the employers must report known cases to employees who have been exposed within 1 business day. And I'm not sure if you guys are doing that, but you definitely want to start incorporating that into your procedures now. The real problem with this bill that CAF had was that it gives CalOSHA expanded enforcement authority to shut down any business, really, not just skilled nursing or intermediate care, but any business they could shut down if they deemed it was a workplace safety violations. And when we had conversations with the director of DIR, this was one of the things we mentioned, that, you can't just go in and shut down a skilled nursing facility because there's people that live there. And so we have to incorporate both the local health department and the California Department of Public Health if there becomes enforcement issues that are so serious that you would consider shutting a facility down. And we got really positive feedback from the director saying, look, we're not interested in shutting down healthcare facilities. We're going to work in conjunction with the other regulators to determine the most effective course of action. So I think that is the last thing they want to do. Even though it's written into the bill, I don't get the impression that they're out there even seriously or remotely considering that as an option. All right, so AB 2644 is the one that requires a full-time infection preventionist, and it has some reporting requirements as well. So report each disease-related death or suspected disease-related death to CDPH within 24 hours. Full-time dedicated IP, who's either a registered nurse or an LVN, have a plan for infection prevention and quality control. And you're going to be required to have infection prevention and control training on an annual basis. So that's for all healthcare personnel are going to have some component of their annual training has to be in infection prevention and control. It's not specific as to what that is, which is good, and we can work on developing training that will meet that kind of need. But this goes into effect. I'm not sure if it's effective immediately. I think it actually has an implementation date, but I can't remember off the top of my head. But I can, if you guys are interested. I don't think it's effective immediately. But Deanne, do you know if this one has an implementation date of January 1?
Let's see. I think that it is, unless there was a designation that says it would start immediately. So it should be January 1st.
Yeah, and that's what I thought I read. I read all of these bills this morning again, guys, and it's like it's such dry reading. But I'm pretty certain this one is effective January 1. And Two other pieces of legislation that were positive to us were the AB 90 expansion of nurse practitioners that goes into effect January 1, as well as AB 2288, which I think has a longer implementation date. I don't remember when it goes into effect, but it affects nursing programs as well. And we did manage to get the governor to veto Senate Bill 1207, which would have required 96 hours of fuel on site, as well as your building would be required to maintain safe temperatures throughout the duration of an emergency event. And we had very serious concerns that safe temperatures was a very nebulous term that was up for interpretation. And we did not want a piece of legislation that would force everybody to upgrade their air conditioners and their generators to be able to maintain safe temperatures through the duration of an emergency event. Now, that doesn't mean that we don't want you guys to have a plan to deal with that. It just means that a hard and fast requirement would have forced us to address our built environment. And depending how it was interpreted, it could have been well over $1 million in physical plant improvements for each individual facility in the state. So it would have been extraordinarily expensive if we did not get this bill vetoed. Now, it was put, frankly, I don't know the correct terminology, but we're going to have a work group or an advisory group that talks about the elements that went into that bill. So it's not dead yet. It may come back, but we're going to work to get the safe temperature designation removed out of there. The CMS emergency preparedness requirements require us to have a plan to keep our generators functional for 96 hours. We want the state law to follow that CMS guidance, and we will work with them to make sure that it doesn't deviate from the CMS requirements. All right, so that gets through legislation, and that all came out last week. So thank you to Amy for giving me all the information on the bills and preparing those handouts for you guys. So I want to say thank you guys. Let's get to some questions. Let's see if I have any questions this week. Give me a second. I got to expand these. Holy cow, there's a lot of questions. Forgive me, I got to get to all the way to the beginning. All right, so some of us are in counties whose public health officials still prohibit visitation. Yes, absolutely, and that we anticipate that's going to continue to be a problem. And so my suggestion to you is once you get that AFL on visitation, depending on the health department that you're in, I would have a conversation with them. If you're in Los Angeles has what they call the ACDC manual, or Acute Communicable Disease and Control. I can't remember the total acronym, but they have a manual that they address every single thing about operations within a skilled nursing facility during the COVID response. And so they're great about putting that information out so that you can print it out and you know exactly what it is on a daily basis. You know exactly what LA's minimum requirements are. In other counties, I don't know that they're doing that as well. Some of them have produced guidance documents and done that. I don't know. I don't have enough view as to whose health department is going to follow along. But my suggestion is, as soon as you get the AFL, take the big elements out of it. Are we going to open up for visitation? Are we going to restrict it in any manner? Is it going to be restricted to the outside? Is it going to be restricted to people that can prove they've been tested? I don't know what they're going to come up with, but clearly they have the ability to be more restrictive. Just wanted to clarify, if our county positivity rate is in the low medium, with positive cases due to our capacity to admit COVID positive residents, can we still do indoor visitation if our positive cases are located in a separate? So yes, I believe they're going to have something in there about whether you're in an outbreak, but they changed the definition of an outbreak. And so I don't think if you take let's say you take an admission from a hospital who's COVID positive, that doesn't automatically make you an outbreak facility. And so I think there's some nuance to how you're defined as being in an outbreak status. And that nuance was changed last week by CDPH because they no longer define an outbreak as one healthcare worker testing positive for COVID. So that in and itself is subject to the local health department. The local health department could say, nope, one healthcare worker is an outbreak. You're in an outbreak status. And if that's the case, you're probably only going to be able to do outdoor visitation. But I highly encourage you. This is one of those nuanced things that you're going to have to definitely get approval from your health department before you jump forward. So the physician, next question. So the physician's order for family testing is an issue. Our medical director has spoken with her attorney, who is concerned and likely not going to give a hard no to her ask, and patient-doc relationship. So that's a good point. Like, can our medical directors order the test for somebody that's not their patient? Frankly, I don't know the answer to that. And I probably have to ask Dr. Steinberg or somebody from CalTCM about the legality and what their responsibility is. But that would have to be answered by a doc or an attorney. Anyway, CAF, Legal Brain Trust. You know what? And this question is from one of our regular contributors. I will ask our general counsel if there's anything that we should be considering, or is there any guidance that we can give the medical directors? All right, I'm going to move to the next question. If facilities choose to screen visitors, and by screen, I think you mean screen testing visitors or using the antigen testing devices, who will be responsible for the cost? If you're just talking about well, in all instances, you would be responsible for the cost. You can't pass the cost off on the visitor. I don't think that's appropriate. But if you have one of the antigen testing devices, you would be responsible for their cost. I guess maybe you could find a way. No, I don't think you can. I just don't think there's any way to recoup that cost if you're going to offer the antigen testing for your visitors. If you're just talking about the screening, that should be done by an employee. So that, or possibly a volunteer maybe. But yeah, you're responsible for all the costs of screening visitors, whether it be the screening process or the testing itself. Do facilities have to have family members to sign consent and waivers? And I saw nothing in the CMS guidance that spoke to that. And I've taken a look at the draft AFL that's going to come out, and I didn't see anything that talked about having family members sign consent forms or waivers. Deanne, do you know of any facilities that are currently doing that have already started visitation?
I know that people are having individuals sign off that they are, their screening is done and that they are honestly answering the screening, those types of things, but nothing beyond that yet. But in the guidance that we had talked about when doing visiting was to consult your legal counsel to see if your organization is going to want to have that in place, because just like they could bring in the infection, there's always a possibility that we just don't know one of our team and they potentially could pick up an infection from the facility, less likely but possible. And so you might want to have them sign something that says, I understand the risk, and also potentially I understand that I need to inform the facility if I should show any kinds of symptoms in the next 2 weeks. So it's a possibility. I don't see it anywhere as a requirement. I think that would really be your legal counsel that would decide for the organization if they're going to choose to go that direction.
Yeah, and Deanne brings up great points. I'd not thought of it. I was thinking more from a regulatory, this is your requirement, but from a perspective to protect yourself and to protect your, protect liability exposure, you'd want to make sure that you document that folks are have self-certified that they're not exhibiting any of the symptoms, because many of the symptoms in the screening questions are not observable. In other words, you can't see whether somebody has fatigue or not. So there's some of those things where you're relying on them to relay that they actually do not or do feel this, and to have them sign something, some kind of statement or attestation that says they didn't, I think that would be well within your rights, but I don't know that it's going to be a requirement for you to do it. But I think it's probably a good practice to implement if you've not already done it. So the next question is, please advocate for us to get reimbursed for additional PPE, and absolutely we will. So any cost as a part of our AB 1629 deal, we ask for rate add-ons, and that'll be a pretty substantial one. Before the bill was passed, we gave them cost of implementation, so they are familiar with what we anticipate the cost will be to do that. The problem is we don't know exactly all the categories they're going to require on PPE. We don't think gloves are going to be included in that, since that's a normal everyday use item. So if we can get the gloves removed, which we know gloves are disposable, so it's every interaction you have with a resident, you remove a set of gloves. That, times, how many times you go into a room, every day, it's an exponential number of gloves. So for things like that, we've talked to them and said, look, it's not even realistic for us to have 45 days of gloves. It's, I would need 3 storage units just to store my gloves. And so they understand that. So that's the term surge supply. And that's where CAF and the other stakeholders on the work group will talk about what surge supply means. It's not going to be, at least our advocacy is not going to be around disposable use. It's going to be a surge supply based on extended use of potential things. I don't think it's realistic for us to anticipate that we're going to have enough PPE in stock to be able to get through another pandemic like this. It's just, unless we're manufacturing them in our parking lot. So we will definitely advocate for common sense total amount that's going to be required. And then once that is determined, then we'll be able to give them an exact cost of how much they need to reimburse us for that. We'll get PPE whatever they want, 3 months, 1 year, as long as they pay. Yeah, that's exactly right. Yeah, our issues were not related. So when we did not want to do or had reservations about the bill, it was not about cost, because we figure we can get that in there. It's about capacity. And if you have to have 45 days of disposable use of each one of the PPE items, and they expect you to have enough for every resident and staff, then you go, well, we can't do that. We just don't have enough space. So we had to come up with this kind of surge guide that's undefined at the moment, but we'll come up with that. So, all right. Says, again, please, can you clarify the updated sick leave changes? Yeah, well, sorry, I took the 500 plus employees directly from Amy's handout. So please follow Amy's handout, Maggie. I am not the legislative director, and literally this is literally 2 days old, and I read through it just enough to put it on the PowerPoint last night at 11 o'clock. So I don't have a lot of depth in my knowledge on the legislation, but I suggest following the guidance from Amy. And if you have questions, bloomberg@caf.org, you can email her and she'll be happy to answer any questions you have about the legislation. All right, if our, let's see, I'm trying to get through all of these. We got a bunch of questions, guys. If our county positivity rate, and I think I already read that. Physician's order for family test, oh, sorry, I read that as well. Actually, I might have got to the end of it. with regards to visitation, would the facility follow the county by 2 weeks? And no, I don't think so. So somebody had asked that, in the original visitation had said, 2 weeks after your county. That's not going to happen. It's just going to, when the AFL comes out, it's just going to say, here you go. You're ready to go. You're already in that category, the low to medium risk. You're ready to go. So, all right, guys, we're right at 2 o'clock. Perfect timing. I got to the, well, one more question came in. So when you met, talk about specific local jurisdictions. In the city of Berkeley, only 10 gallons of fuel can be stored. So there'll be other issues with that we'll talk about. Yeah, so somebody wrote that in the nursing home QSO, it defines outbreak as including healthcare professionals, but CDPH says patient only. Can you comment? So I don't know that CMS gets to define what an outbreak is, but I'm not certain. But if CDPH releases a set of guidance, that's generally what I'm going to go by. And the CDC guidance has changed as well. So that's a good question, Justin. I will bring that up to Heidi and say there's a bit of a conflict between what's defined as an outbreak in the CMS documentation and what the CDPH released last week. But I would go with what CDPH says and then follow your local health department if they have a more restrictive guide than that. So anything, any parting words of wisdom before we leave, Deanne?
No, I just appreciate you bringing all this information to us. Thanks, Jason.
All right. Oh, thanks, Deanne. All right, guys. Well, thanks. Hopefully you have a great weekend. I'm glad it wasn't that crazy of a week, as long as you're not living in Sonoma County or Napa County. So anyways, take care, guys. We'll talk to you next week. Have a great weekend.